Hello, NephU community, and welcome to today's podcast as we discuss key differences between hemodialysis and peritoneal dialysis. My name is Sean George, Senior Clinical and Scientific Liaison at Otsuka. I will be moderating today's discussion. I am very fortunate to have Dr. Biruh Wokeneh join me today to share his expertise around these dialysis modalities and how he presents these options to his patients that are progressing to end-stage renal disease. Dr. Workeneh is a board-certified internist and nephrologist. He is a professor in renal section and the dialysis medical director at the University of Texas M.D. Anderson Cancer Center. He completed medical school at the University of Texas McGovern Medical School in Houston, his residency training at UTMB, and clinical and research fellowship at Stanford University. His interests over the years have included body compositional changes in CKD and transplant, home-based dialysis, and onconephrology. Dr. Workeneh, thank you so much for joining us today.
Well, thank you, Sean, for that kind introduction. Happy to be here.
Yeah, glad you can join us. So I want to start off with this question around what providers should know as their patients prepare to initiate dialysis, and what are the key differences between traditional in-center dialysis and home-based dialysis?
Wow, that's a big question. So let me first paint the picture and provide a little bit of background. You shared with me our audience includes care providers, nurses, physicians, perhaps patients. And so I'd be remiss if we did not spend a little time on preventing the progression of chronic kidney disease. As you know, there's over 40 million Americans with chronic kidney disease. That's 1 in 7. Many who have never seen a nephrologist. There are plenty of opportunities now to optimize medical management and prevent dialysis. And there's an explosion in research in chronic kidney disease. And there's been some recent legislation that's been exploring some avenues in terms of research, in terms of pay models to incentivize outcomes. And getting to end-stage renal disease, that's when patients require dialysis. There's over 700,000 patients in the United States who require dialysis. And CMS, that stands for Center for Medicare and Medicaid Services, they fund over $50 billion, that's with a B, to support the care of these patients. And the majority of these patients receive traditional hemodialysis, about 90% or so, and increasing number of patients are receiving home-based dialysis. That's around, I think the last number I saw, around 13%. So to answer your question, traditional dialysis is a mode of dialysis where a patient goes to a center. You might have seen some dialysis centers along your local strip mall, and there are some standalone centers that exist. And it's where patients come to the center and sit in a nice, comfortable chair and connect to a machine for approximately 4 hours, 3 times a week. The typical schedule is either Monday, Wednesday, and Friday, or a Tuesday, Thursday, and Saturday. Those are the 2 traditional typical regimens. And the home-based dialysis include a couple of modes. The first is peritoneal dialysis. Peritoneal dialysis is a type of dialysis where the patient uses their own body to clean the blood. The lining of the abdomen does the cleaning and the filtering. And then there's a second type of dialysis, of home-based dialysis, called home hemodialysis. And this is where patients use a simplified dialysis machine where it's placed in the patient's home. The patient is trained how to use that machine, and they administer dialysis themselves at home. So that's the big picture and a little bit of details about what the basic things that I think everyone should understand about dialysis.
No, that's great. Thank you for sharing that with us. And you said the percentage has grown to about 13% when it comes to home dialysis, correct? That's better.
Right.
That's better, but it's still not great. And I guess it's taken a long time to get to that 13%. Why has it taken that long to get there, in your opinion?
I think it's straightforward. So let's just start off that something that every patient should know, every provider should know. When they canvassed a nephrologist, nearly 90% of nephrologists would pick a home-based therapy for themselves. So
Yeah.
why do we see the complete opposite of that? When it comes to our clinical practice patterns, and part of it is I'm not focusing on the patient. I think we should focus on the providers, and not that providers don't want to provide education to their patients. I think everyone in that position does. Certainly, providers want the best for their patients. It's about familiarity. It's about
Hmm.
comfort level. Do they understand how to prescribe it? And so I'll just give you a little anecdote. For example, I was trained at Stanford, where home therapies was emphasized, and I was completely comfortable after my clinical fellowship. My continuity clinic, I cared for the patients on an ongoing basis for 3 years. So by the time I left, I was comfortable with it. And my first stop was at Baylor College of Medicine. I think they had less than 5 patients at the time receiving home-based therapy. And so, long story short, a few years later, our census was over 100 home-based patients, primarily peritoneal dialysis, but also patients on home hemodialysis. And so certainly bringing in someone with experience, with comfort level, someone who knows how to explain to patients the merits of home-based therapy, I think it's critical. And so I think that's, to answer your question, how we increase the number of patients dialyzing at home. It's educating the care providers. So when you educate the care providers, they educate their team. The team is comfortable with it, and then certainly that means they can explain it to patients and help them feel comfortable about going home.
Yeah, that's some great insight. Thank you for sharing that. So, what are some factors that determine which road to take when it comes to choosing a dialysis modality?
Well, the factors are complicated, and I can certainly list them, but I think the most important thing a provider can do is talk to their patients and have a frank conversation about what they want. How do they want to live their lives? They want to continue to work. Can they simple things like, can they see? Do they have any visual impairment? Is there family support? And so anyway, we take all these inputs and then we help guide them. We don't choose. I wouldn't recommend choosing dialysis modality for a patient, but we do have to contextualize all these considerations for our patients. And I think that's what the role of a nephrologist is to contextualize and say, look, have you considered going home, for example? I think maybe you'd be a great candidate. And so that conversation is complex, but something that can be learned, and I do it every day. I'm a still practicing nephrologist, and so these conversations, I think providers need to learn as they're training. We're talking even if level of medical school. I think medical school students need to be familiar with at least the concept of home-based dialysis, so it's not so foreign. And certainly as they go through their internships and fellowships, I think it's important to get some exposure. So all physicians, just in general, including primary care physicians, have a first line. The first person you see is your PCP.
Right.
And so before you're referred to a nephrologist. So I think it's good to raise the awareness. So that's why I'm so grateful for podcasts like this, where we can get our message out.
Absolutely. So whenever you're counseling a patient, you're sitting down with the patient and talking to them about the different modalities of dialysis, whether that's home hemo, peritoneal, or in-center. When you start talking about home hemodialysis or peritoneal dialysis or doing dialysis at home in general, do you sense hesitancy from the patient typically? or do you find them having a sense of relief that they can actually do this at home, or does it just kind of vary from patient to patient?
So, good question. I think there's two categories of patients. One set is highly unfortunate, which is where patients don't receive the pre-morbid or the pre-ESRD or ESKD care, where they're seeing a nephrologist, where they know their creatinine number, and so they just show up in the ER because they can't breathe. They show up in the ER because they have palpitations or they're feeling weak or they develop swelling, and lo and behold, their creatinine is 10, and it's a shock. And so these are patients who crash, what we term in our parlance crashing to the ER because they weren't identified early, or perhaps they have a disease where their kidney function just deteriorates in a very short amount of time. So sometimes it's unavoidable, but in the best case scenario, it's the second group where kidney disease is identified, where it's managed, where the underlying cause is addressed, and despite best efforts, the kidneys continue to deteriorate, and that gives the provider and the patient time to consider all the dialysis modes and to think about what's best in terms of lifestyle and quality of life.